Hello everyone, I'm Dr. Tan here. Welcome back to the channel. Today I'm going to share with you a very important medical emergency, which is pulmonary embolisms. This is the lecture overview. First, we are going to start by taking a look at the disease prevalence, on how common PE is and why you should always keep it on your clinical radar. Next, we'll learn about the disease pathophysiology and clinical manifestations. After that, we'll go through the key diagnostic workup. And finally, we will take a look at the disease risk stratifications on how to figure out or establish the disease severity and to decide the right management. So by the end of this video, you should have a clear framework for understanding PE and how to apply it in your real clinical practice. Let's begin with the PE prevalence. Pulmonary embolism is not exactly a rare condition as what we have previously thought of. So when we look at the broader picture, which is under the umbrella of venous thromboembolism that includes deep vein thrombosis and pulmonary embolism, is in fact the third most common acute cardiovascular syndrome worldwide, and after myocardial infarctions and stroke. And the annual incidence of pulmonary embolism is estimated to be 39 to 115 cases per 100,000 people. So the key message from this slide is simple. PE is not as rare as we have previously thought of. It's clinically significant and it must always remain on our radar in our everyday medical ward practice. On top of that, an autopsy study by Steen and colleagues found that 70% of patients who died from pulmonary embolism were not suspected to have the condition before their death, meaning to say that the diagnosis of PE was only diagnosed during autopsy. So this highlights a critical challenge in our practice because it's logical to assume that there will be a time PE may just go undiagnosed until it's too late, or sometimes the diagnosis of PE was even missed, it was misattributed to other causes. And all this will actually obscure the full impact of these conditions. In other words, the prevalence of PE in our real life practice could be even higher. So this underscores a vital importance message, which is important for us as a clinicians to maintain a high index of suspicions for pulmonary embolism when we are dealing with patients with acute respiratory symptoms. Early recognition and timely interventions can definitely make a difference between life and death. Now we will pivot to the next section of the lecture today, in which we are going to discuss about the pathophysiology of pulmonary embolism. In order for us to fully understand the pathophysiology of thrombosis, it is important for us to acknowledge where this understanding began. On my right hand side, this is Rudolf Virchow. He was a German physician as well as a pathologist, and his work laid the foundations for modern pathology. Through his research on venous thrombosis, he described what we now call Virchow triad, which is illustrated on this figure on my left hand side, which comprise of three fundamental mechanisms that predispose to thrombus formations. So what are the three components in the Virchow triad? It's actually represented by endothelial injury, and number two will be the abnormal blood flow, also known as stasis, blood stasis. Number three will be hypercoagulability. So all these conditions added together will actually predispose an individual to develop thrombosis. And in the case of pulmonary embolism, it will be formations of blood clots in the pulmonary vasculatures. So here are some of the examples or conditions that will predispose the patients to develop thrombosis, and you can take a look at it at your free time. So previously we discussed about the general principles of thrombosis and its causes, and now let's focus on pulmonary embolism. So according to this theory, embolic phenomenon theory or the migratory clot theory, it says that the pulmonary arteries does not form there spontaneously. Instead, it's believed that the clot originates in the peripheral vascular system and travels to the lungs, causing obstruction in the pulmonary vessels. And this process involves embolizations and propagation of the thrombus from the peripheral veins, leading to secondary occlusions in the more distant vessels, such as pulmonary arteries. So a classic example would be when you have a clot in the deep veins of the lower limbs, which get dislodged and migrates to the pulmonary arteries, resulting in pulmonary embolism. So understanding this migratory behavior of clot is very important because it will allow us to take preventive steps as well as to detect and manage pulmonary embolisms timely. While the classic migratory theory explains pulmonary embolism as a clot traveling from peripheral veins, recent evidence suggests that there is an alternative mechanism called de novo thrombogenesis. In this model, thrombosis arises directly within the pulmonary arteries without originating from deep vein thrombosis. This phenomenon was historically under-recognized, but it became more apparent only during the COVID-19 pandemic. So de novo pulmonary thrombosis is thought to be a result from endothelial dysfunctions, systemic inflammations, and also acute lung injury, which together create a local environment that promotes clot formations. Understanding these mechanisms is important because it highlights that the pulmonary embolism is not always caused by peripheral clots and has important implications for our preventive strategies. Just to share with you two researchers in which we reported the prevalence rates of pulmonary thromboembolism in two different cohorts. One would be those infected with COVID-19, and another one will be amongst our pregnant mothers. I think it is worthwhile for you to look at the discussions of these two papers so that you can get some insights on other aspects of a pulmonary embolism. So all in all, despite advances in our understanding of thrombosis and the recognitions of newer mechanisms known as de novo pulmonary thrombogenesis, our workhouse triad continues to hold true because it remains as a fundamental framework for understanding the underlying factors that contribute to clot formations, which will be represented by three risk factors: endothelial injury, abnormal blood flow, and a state of hypercoagulability. And it always serves as a guiding principles for both research and clinical management of thrombotic disorders. And here are the list of risk factors that will predispose an individual to venous thromboembolism. Doesn't matter is it a PE or DVT. We must always, actively elicit these risk factors during history taking. For example, like any factors that contribute to immobility listed here. Whether does the patient is using any hormonal therapy that elevate the risk of thrombosis, does the patient have any underlying malignancy, and so on. So because by detecting the risk factors that combine with the patient's histories, it will give us a stronger convictions to investigate further whether is this really due to pulmonary embolisms or deep vein thrombosis. Now let's switch our attention to the signs and symptoms of pulmonary embolism. So, what are the clinical features of pulmonary embolisms? As you can see here, patients can present with a spectrum of symptoms ranging from mild to life-threatening symptoms. However, common manifestations include dyspnea, which is shortness of breath that often occurs suddenly. Chest pain, typical pruritic in nature, but can resemble angina if a right ventricular ischemia occurs. Or they can present with pre-syncope or syncopal attack. Hemolysis will be one of the more serious spectrum, and also hemodynamic instability in severe or massive pulmonary embolism. Recognizing these features promptly is critical for early diagnosis as well as institutions of the pulmonary embolism treatment. It is also equally important for us to remember that these symptoms are non-specific and they can mimic many other medical conditions. That's why it's critical for us to actively screen for risk factors towards venous thromboembolisms, like considering the underlying conditions, recent surgery, any history of immobility, underlying malignancy or thrombophilia conditions. And also to correlate it clinically with the patient history and physical examinations, and also we will tie it up with a blood investigation, for example, D-dimer, when used in the appropriate context, and integrate this with our preliminary imaging, particularly echocardiography, which can detect right ventricular strain obstructions in more severe forms of pulmonary embolisms. So by combining these findings, clinicians can calculate the pretest probability of PE, which will guide further diagnostic tests as well as management decisions. Well, we have discussed the spectrum of pulmonary embolism from the classical symptoms and risk factors to incidental findings on imaging. While many cases can be detected early, PE also can sometimes present dramatically with sudden cardiovascular collapse. So in patients who deteriorate to extremis or cardiac arrest or refractory hypotension, it's critical to follow the standard advanced life support algorithms while keeping pulmonary embolism in mind as one of the potential causes. ALS encourages us as clinicians to systematically consider reversible causes using the 5H and 5T's framework. The 5H here will be represented by hypoxemia, hypovolemia, acidosis, hypo or hyperkalemia, and as well as hyperthermia. Whereas the 5T will be represented by thrombosis, which happens in the lungs or in the cardiac, tension pneumothorax, tamponade, as well as toxins. Before I give you the predictive scores that are commonly used in deciding the likelihood of pulmonary embolism, I must emphasize again that in clinical practice, the suspicions of pulmonary embolism will be a clinical gestalt, especially for experienced clinicians, because we make the decisions whether to pursue on the CTPA or not is based on combinations of these, which is very much the same for you as well. Through thorough history taking, especially identifying the risk factors, physical examinations, correlations with the preliminary lab results, or even imaging tests, so that we have, mind, we will try to run out the competing diagnosis. If still PE is a possibility, only then we will pursue the further diagnostic steps, which is CTPA. Also, I'd like to share with you that I think studies show that overuse of CTPA sometimes can lead to overdiagnosis of pulmonary embolism. And hence, all in all, I think the use of this gold standard test, which is CTPA, must be justified by the history, examinations, as well as the correlations with these lab results and other imaging tools. So here are the top 3 most commonly referred to PE predictive scores. I'm sure that you guys are very well versed about this WELL score. But besides WELL score, we have other predictive scores as well, like revised Geneva score and also the PE rule-out criteria. Even though they are more or less the same, but there are nuances, differences in which I have already summarized in this table because, for example, for WELL score, it includes clinical judgment. You need to make a call, is it likely or not, before you can come up with a composite score to tell how likely the patient is having pulmonary embolisms. And then it's applicable for low, moderate, and high risk, and also it can be used before D-dimer result, and it's best for general ED and inpatients. Yep. All right. I think also important for us to to understand whether this score has been validated in other special population as well. Like for examples, like pregnant mothers. Revised Geneva scores, there is another versions which can be used for pregnant mothers. But I would like you to read about the following articles and I'll share with you because we have actually done validations in our pregnant mothers populations. And it's quite interesting, the findings. Please go and take a look at it. Well, this is the paper that I have mentioned earlier, in which we have done an external validations for these pregnancy adapted Geneva scores, and the finding is quite interesting. If you're interested, you can search for this paper and take a look. So before I move to the next sessions, I would like to introduce you to Bayes' theorem, which is the foundations that researchers based on when they first started looking into the predictive score. So I think it says that the probability of a disease is updated by combining the pretest probability with the diagnostic test result and its accuracy. And the failure rate is dependent on the pretest probability of having a disease. I think to understand more about this Bayes' theorem, you can refer to the reference that I have put it up so that you have some idea like what was the historical aspect of this predictive scores and how does it come around in the modern days. So here are the key diagnostic tests that can help us to arrive at the diagnosis of pulmonary embolism. Of course, the gold standard will be CT pulmonary angiography, which has the highest sensitivity as well as a specificity among all these 4 tests. And also it is a test that we can use confidently to rule in as well as to rule out pulmonary embolisms. The first test that we are going to look at will be none other than the ECG, because it's the first test that will be available because it's a bedside test. The classical description of the ECG changes in PE would always be, deep S wave in lead 1, and also Q wave in lead 3, and T inversion in lead 3 as well. However, this test carries one of the lowest sensitivity and specificity amongst the other tests mentioned here. In the next slide, I'm going to share with you more about what are the features of ECG that are commonly reported in patients with pulmonary embolism. Wow, here it is. I think in practice, I think the most commonly seen ECG changes will be none other than sinus tachycardia. Sometimes, yes, patient may have S1QT T3 patterns as seen over the ECG here. As you can appreciate that there is a deep S wave in this lead 1, and there is a pathological Q wave accompanied by T inversions in lead 3 here. Not infrequently, sometimes they may have a QR pattern in V1, incomplete or complete right bundle branch block, or sometimes they may present with a right ventricular strain pattern such as T inversion in lead 1 to lead 4. If that's the case, you see is there any ECG abnormalities, always send a troponin I for prognostications, and also keep at the back of our mind, sometimes patients with pulmonary embolisms, I mean, most of the time this will be the cohort that are having a more severe PE. They may actually develop atrial flutter or atrial fibrillations as well. Another test would be POCUS, which stands for point of care ultrasounds. It carries a sensitivity of 45 to 61% and specificity of 74 to 90%. I think POCUS is not only used to rule in or rule out PE, also at the same time to help the clinicians to rule out other competing diagnoses, like for instance acute pulmonary edema or pneumonia or pleural effusions. It may come in very handy. But of course, in the context of pulmonary embolisms, we will be talking about pulmonary embolism that's more severe, because a stable or a mild P, a lot of time, I think the POCUS may not pick up much features. But of course, the POCUS can always help us to detect whether is there deep vein thrombosis. That may teach to the diagnosis of pulmonary embolism is the patients have concurrent DVT. Point of care ultrasound, or POCUS in short, is actually a very useful tool in evaluating the hemodynamic status of a patient, not only in pulmonary embolism, but as well as in other medical, acute conditions. So in pulmonary embolisms per se, most of the time to have these features are listed here, such as enlarged right ventricles, McConnell signs, most of the time the patients would have some degrees of hemodynamic compromise, because it represents, effect or effect or have an impact to the cardiac functions. So what are the features commonly seen will be enlarged right ventricles, as well as a McConnell signs, in which I'm going to talk about it in details later on. Also, if let's say the pulmonary embolisms arises due to the embolizations that clot from the lower limb DVT, not commonly, sometimes you may be able to find the right heart mobile thrombus called clot in transit. So basically, it gives you evidence that the thrombus that now has a lodge in the pulmonary embolism most likely arise from the lower limbs. Other echographic features of pulmonary embolisms, again, I would say that this could be found only in patients with more severe spectrum of PE. Will be the 60-60 sign, decreased TAPSE, decreased peak systolic velocity of tricuspid annulus. And also it's important to highlight here that The onset of right ventricular failure, which characterizes submassive MSP, is the principal driver of a short-term mortality. A lot of time you see that it's a hemodynamic compromise. I think it's worthwhile to send a troponin ISO prognostications. So next we're going to talk about this McConnell signs. So one of the eponymous signs that commonly reported in the literatures when we are talking about patients with massive or submassive pulmonary embolisms. So what is McConnell sign? So it is defined as akinesis, a lack of movement of the right ventricle's free wall with reserved or hyperdynamic contractions of the apex. I have inserted the video links in the descriptions. Later on, you can take a look on what's McConnell signs. Because this is just a still image, you will not be able to appreciate much on these McConnell signs. In the context of pulmonary embolisms, whether is it suspected or confirmed pulmonary embolism, it suggests that there is a significant right ventricular strain that has already caused a right ventricular ischemia, and it has important bearings on the next course of actions. For example, in the patients that already have hemodynamic compromise with a refractory hypotension, a patient may be labeled as a massive PE. It may warrant even thrombolysis therapy. Before we move on to the next slide, I'd just like to emphasize again is that McConnell signs it's just a sign that indicates the presence of right ventricular ischemia. And it has a different sensitivity and specificity depends on the populations that you are looking at. Hence, McConnell signs cannot be used in isolations. It must be combined together with the patient's clinical symptoms and hemodynamic status to decide the action plan. But of course, at times of emergencies, McConnell signs would be useful, especially for patients who are unstable to undergo further diagnostic tests like CTPA. So just would like to share with you some of the articles that reported McConnell signs as well, in the absence of severe pulmonary embolism. Next, we are going to take a look at D-dimer test, which is one of the tests with the highest sensitivity after CTPA. You can see here that the sensitivity of this test carries about 99.5%. And because of its high sensitivity, sometimes this can be used as a rule-out test for pulmonary embolism. On the downside, the specificity of this test is very low, as low as 41%, which is the lowest amongst all these four tests in the table. So what is D-dimer? D-dimer is actually an indirect marker of fibrinolysis and fibrin turnover. It's a soluble fibrin degradation product that results from the systemic degradations of vascular thrombi through the fibrinolytic mechanisms. As I have alluded earlier, D-dimer carries a very low specificity, and the primary reason is because D-dimer will be elevated in the constellations of clinical scenarios, ranging from sepsis, cancer, pregnancy, and etc. And further, it also lack of clinical standardizations. Now we come to the final part of the lectures in which we're going to discuss about the gold standards for the diagnosis of pulmonary embolism, which none other than CT pulmonary angiography, which carries very high sensitivity as well as a specificity as illustrated here. Well, this is just a photo to illustrate to you as a CT scanner. So what are the strengths of and weaknesses of this CTPA? Yeah, since it's widely available, I think we can use this to rule in or rule out pulmonary embolism. We must also be cognizant about the strengths and weaknesses of this modality. So the strength of CTPA is that it's readily available around the clock in most centers. It has excellent accuracy, as I mentioned earlier, has a low rate of inconclusive results, and may provide alternative diagnosis if PE is excluded. It has a short acquisition time. So the weaknesses are radiation exposure to iodine contrast, and the tendency for overuse. And sometimes the clinical relevance of CTPA diagnosis of subsegmental PE is unknown. And patients in respiratory distress may not be able to lie flat for such an imaging procedure. In the case, you need to depend on others imaging modalities. Especially, I think POCUS would be very helpful in the case that patient was unstable to be sent for, CT PA. So when talking about PE, I think it's worthwhile for you to understand the anatomy of the pulmonary vasculatures, where is the pulmonary arteries, how does it branch out, what are the further subsegments of these pulmonary arteries. So all based on the involvements of the different sections of the pulmonary arteries. It can be labeled as extensive PE, saddle PE, central PE, lobar PE, subsegmental PE, or segmental PE, depending on the location of the clots. So these diagrams illustrate to you how a saddle embolism look like. You can see here there is a hypodense clots over here that has caused complete occlusions of the left pulmonary arteries and near complete occlusions of the right pulmonary arteries. Here's another diagram, which is taken from a case report that I have published this year to illustrate to you on how the saddle embolizer look like. You can see the clot is actually sitting at the bifurcations of the main pulmonary arteries. And on top of that, this pulmonary embolism has also caused right lower lobes pulmonary infarctions. So we are going to end the presentations by looking at the risk stratifications of pulmonary embolisms. So broadly, it can be classified into a massive PE, also known as a high-risk PE, defined as a PE causing hemodynamic instabilities as described below. We can be at the need for CPR, like due to cardiac arrest, or patient has hypotension, defined as systolic blood pressure less than 90, or vasopressors required to achieve BP 90 and above despite adequate filling status associated with end organs hypoperfusions, or there's persistent hypotension not caused by new onset arrhythmia, hypovolemia, or sepsis. So another subset would be a soft massive PE with intermediate risk PE, defined as a hemodynamically stable PE with right ventricular dysfunctions, which will be characterized by your point of care ultrasounds or the comprehensive echocardiogram. Lastly, what we most commonly seen in our practice would be this low-risk PE, defined as a hemodynamically stable PE without right ventricular dysfunctions. So these classifications are important because it will guide us on the treatment strategies. Another scoring system we will use to classify whether the patient is high risk, low risk, or intermediate risk would be this pulmonary embolism severity index. In short, we call it a PEPSI score. It's actually a validated clinical scoring system used to estimate 30-day mortality in patients with acute PE and also to guide risk stratifications and management decisions. Thank you for watching this video. Just for your information, I have included some articles which have been kept at the descriptions sections where you can read up more, especially on the managements that I don't have time to cover in these video lectures. But of course, I hope maybe in the future we have time we can go through the management options and also the management strategies in pulmonary embolisms. But all the references used or the references that you need for pulmonary embolism, I have provided in the descriptions for you to read up at your own free time. Thank you.